So we're going to switch a little bit topic and talk about cervical spine. So I took off some slide from my presentation so that we can catch up a little bit with delay. And after this talk, I believe there is 3 additional talks on cervical deformity. So see this presentation more as an introduction. So I'm going to skip this slide. So something that we used to do, like, and it's not specific to cervical spine, but you know, the patient come to your office, it's one piece from head to feet, and we tend like to break down the patient in small little piece and just look at where the complaint is. So most of the patients that do like a cervical surgery, whether it's degenerative or deformity, will get a cervical film. A neutral, a flexion in extension. But as time goes, we realize that, you know what is happening in the cervical spine, if you really want to understand like the pathology, you probably need to have a global look. Because at the end of the day, like you have the cervical spine, and I see the cervical spine like as being like the poor prisoner between the head on one hand, because you need to have like the horizontal gaze, and everything that is happening below. So if below is crooked, the cervical spine is going to have to compensate with a constraint of maintaining an horizontal gaze. And so that's quite challenging for those 7 vertebrae. So let's talk a little bit about like the different parameter. So if you look at the literature, there is a ton of parameter, and we are partially to blame for that. Even for 7 vertebrae, we can talk about 30 different parameters. And so that can be quite scary. And so what I want to do today is not to go over every single parameter of the literature, because if not, I'm going to have to lock the door and keep you prisoner during 2 or 3 days, but just to focus on some key one. So the key one that I think like we need to understand what they mean will be like the cervical curvature. And on purpose, I know it says cervical lordosis, but I do prefer the term cervical curvature, and you're gonna understand why. The cervical plumb line, the focal alignment, so you know the focal kyphosis, the focal spondylolisthesis, the range of motion, and the horizontal gaze. And think about those more as concept, more than parameter by themselves. So let's start by the easiest one, the cervical lordosis. So most of the time, we measure the cervical lordosis between the lower end plate of C2 and the lower end plate of C7. So it's very common. That's a typical parameter. We're going to talk about the normative value. You know, in the literature, you can see between 10 and 20, but this is going to be a big point of discussion in this presentation. So the advantage of this parameter, it's easy to measure. Everybody knows it. But you will see there is a bunch of inconvenience that I want to talk about. The second parameter will be like the cervical plumb line. So you drop a plumb line from C2, and you look at the offset between this plumb line and the posterior superior corner of C7. So what do we know about this parameter? We know that the normative value is about like 1.5 centimeter, which is kind of like the size of the vertebra. So what is nice with anything that has to do with plumb line is that you don't need to measure them. You can just look at them. You know, is it over the vertebra? Is it, so I like to talk in terms of a unit of vertebra. You know, it's like, oh, it's like 3 vertebrae in front. So 3 vertebrae in front is like, oh, it's pretty bad. It correlates with clinical outcome, and that's probably like the main advantage, and that's probably the reason why this parameter gain in terms of interest. And the correlation comes from this paper from Jessica Tang from Chris M. Group, where in fact they looked at on a patient with existing instrumentation, and they demonstrate that the cervical plumb line correlated with the NDI. That was not a very, very strong correlation, but that's why like generated some interest for the cervical plumb line. Something that we don't talk a lot, because it's difficult to measure, will be the dynamic aspect. But that's probably one of the most important aspects, because the cervical spine, you have a huge, or at least you're supposed to have a huge range of motion. And if you want to catch up with the cervical spine based on the horizontal gaze and what is happening below, you need some range of motion. So we did 2 studies. One was on cervical myelopathy, and then we repeated this study on cervical deformity patient, and we demonstrate that among all the cervical parameters that you can think of, including the classic ones, the plumb line, the cervical lordosis, what seems to matter will be like, on one hand, the focal deformity, so the number of kyphotic level, because you can have like a global cervical lordosis despite a few focal kyphosis. The cervical spine is pretty good at compensating, at hiding like the deformity. And so what seems to matter the most on this patient will be like the focal deformity, but also like the range of motion. And this seems to be way more important than just the classic static parameter. And finally, I want to talk about like the horizontal gaze. So there is 2 components. One, there is the upper cervical alignment, between C0 and C2, which in fact you can consider that as being like your reserve of extension. So you can measure it. Or one trick would be to look at like the base of the cranium and to look at the distance between the cranium and the first spinous process. So if the spinous process touches the cranium, that means that there is no more reserve of extension. And we need some reserve in order to be able to function correctly. And then in terms of horizontal gaze, so same, there is numerous parameters, but what seems like to correlate from a clinical outcome point of view will be like, are you able to maintain horizontal gaze and have some reserve to go up and to go down? So what is quite funny with the CBVA, it was first described based on a picture of patient, and the original author described that you need to have a CBVA between +10 and -10, and there was no data. But I guess like this guy like has a good sense of good clinical sense, and we found like very similar range of acceptable value. So this will be the range within which the patient can function normally. So let's go back to the cervical lordosis. So this is a table on asymptomatic subject by age. So if you look at both for male and female, well, the cervical lordosis increase with age. So you probably know why. That's based on, we talked about this morning. When you age, you lose lordosis, increase kyphosis. So the consequence is that the trunk tilts forward, and then what do? You extend the neck. So the classic cervical lordosis changes with age. But that's not all. And here you have some illustration where you can see like a young adolescent, young adult, and older one. Well, it's not huge, but you can see the cervical spine becoming more and more lordotic. And so this raises the question, like, should we always restore cervical lordosis? If you go to a cervical meeting, the #1 criteria of success for an CDF, a disc prosthesis, like anything, will be like the preservation of the cervical lordosis or the restoration. It's like, we gain like 15 degrees of cervical lordosis. I'm like, well, but are you sure this specific patient needed an increased cervical lordosis? And so think about like the cervical lordosis. Like, during year, we looked at the lumbar spine and say, well, the lumbar spine sits on the pelvis, so it should be proportional. Maybe the same concept apply between the cervical spine and the first thoracic vertebra. If we pick T1, the cervical spine sits in the front, so depending on the inclination of T1, we will have like different cervical curvature. So this is 4 different profiles. So the first one will be a lumbar scoli, and you can see like the thoracolumbar kyphosis, but T1 is totally flat. And we have a cervical kyphosis. as you go from left to right, so lumbar scoliosis, asymptomatic subject, Scheuermann patient, and a big sagittal deformity, what is happening is that an increase in thoracic kyphosis, but more importantly, an increase in the slope of T1. As the slope of T1 increase, the cervical lordosis increase. And so we did a study with the SSG and one of our fellow that is now in Denver. We looked at both in an asymptomatic group and then within our patient, what was the proportion between the cervical lordosis and T1 slope in order to maintain an horizontal gaze. So what we found was, and to be honest, I was not expecting this result. We found that if you have a difference between your T1 slope and your C2, C7 lordosis of 17 degrees, then you can maintain a horizontal gaze and still have some reserve in flexion extension. And that was like very surprising to find exactly the same value both on asymptomatic subject and within our patient. So what does it mean? It means that if your T1 slope is 0, you're supposed to have 15 degrees of kyphosis to have an horizontal gaze. And that's quite important because we're not trying to restore lordosis, we're not trying to restore shape, we're trying to restore something that works with whatever is above and below. And then, of course, like you have to be like, it's like everything in life, you know, it's not a recipe in the sense like you don't have necessarily like to change the cervical lordosis. You have to find the driver of the problem. And that's easier to say that than to do it. So if I take like, and Temi, that's the case from Temi, that's one of my favorite patients when I talk about cervical spine, you know, you look at the measurement, so cervical lordosis 52 degrees, T1 slope 84, so there is a mismatch. And now you have to fix something. So obviously on this case, you know, it seems like to be extreme to increase the cervical lordosis. So you want to get access to a long film to see what is the problem. So we have a huge cervicothoracic kyphosis with a huge T1 slope. So in terms of proportion, either you increase the cervical lordosis, which is not the problem, that's the consequence, or you fix the problem, which is a cervicothoracic kyphosis. So the T1 slope minus CL is telling you if there is a mismatch, and then you need to evaluate the full X-ray or the patient from a clinical point of view to understand which one should be corrected, the T1 slope or the cervical. And so this opens the door like to cervical deformity, and I love cervical deformity. I think it's super interesting, and we are only at the beginning. Just to tell you like what we did with SSG, so we start a prospective study like a few years back, based on we knew that there was a need to study this pathology, but we were unable to really define it. So we came up with like some inclusion criteria that everybody accepted. A cervical kyphosis of 10 degrees, a scoliosis, and a little bit of plumb line. And we did our prospective study. And now we decided to stop this, and you will have a few presentations on this topic. But now we are so far ahead from wherever we started that we decided to close the study and do a new one. Because as you know more, we know you need to adjust your inclusion criteria, adjust your study design. So cervical deformity, like very similar to adult spinal deformity, it's not just a bad X-ray. It has a huge impact on the quality of life of those patients. If you compare like the disease burden to classic pathology. And it's probably even worse than adult spinal deformity. It's also usually related to patients that are like on the older side, very sick, very frail. I mean, we have a very high rate of mortality that is not necessarily associated due to the surgery, but those patients are extremely sick. And so I think it was like two years ago or something like that. We sit down in a room with all like the surgeons that are involved in this prospective deformity, and we're like project, and we looked at every single patient. And the plan was to define, is that a severe deformity? Is that like, oh, you know, it meets the current criteria, but now that I think about it, it's not a bad deformity? Or is that, I don't know. Because since we were not at the point of having a very defined criteria, but you as a surgeon, when you see a film, you're like, well, that's a deformity. But if I do the measurement, maybe it doesn't fit the criteria. Because think about like the focal deformity. You know, sometimes you see the cervical spine is like, it's a total mess. But then you don't have a global kyphosis. You have a bunch of focal kyphoses that are compensated. So I think like cervical deformity, up to like maybe 2 years ago, or maybe still today, that's something that you recognize when you see it, but we cannot really quantify it. And so that's what we try to do with a set of different studies. But first, we had to define what was a cervical deformity. So that was based on a consensus approach. So 12 people, 11 surgeons and myself, and we all agree, yes, this is a severe sagittal deformity, or this one is like either no or I don't know. And based on that, we could apply some statistical analysis to try to extract from those patients that were identified as being like with a cervical deformity, what drives the decision. So what we found was quite interesting. So, of course, like we found like the classic parameter, like the lateral plumb line, so the cervical plumb line, the T1 slope, but more importantly, what defined a cervical deformity was actually based on the extension film. So if during the extension you still have a focal deformity, or you still have like so the C2 slope, and I think like Timmy, you're going to talk about it, is like something similar to the TSCL, but the result of the analysis was that without knowing it, the cervical deformity is mainly defined based on the cervical alignment in extension. And so we use this result to try to identify different morphotypes of cervical deformity. And that was done using a cluster analysis. So it was not based on a priori design. We have our data and say, like, which patient looks the same? And we found like 3 morphotypes from a sagittal point of view. The first one on the left is a focal deformity. So you do have a several level with a focal kyphosis, and this kyphosis, focal kyphosis, is maintained in extension. The second type, we call that like the lack of compensation. So the extreme case of that will be the chin on chest. So basically those are patients that have a huge plumb line, cervical plumb line, but when they're on the table or when they extend the neck, they can correct partially the deformity. So maybe there is a soft tissue component on those patients. And the third type, which we do have a lot in the database, is a cervical deformity due to a thoracolumbar problem. So let me explain. Like, if you have an existing thoracolumbar fusion, maybe up to T2 or T4 with a PGK. So T1 slope is like this. You're going to try to compensate, and even if those patients compensate a lot, it's not sufficient based on the thoracolumbar alignment. And that's the 3 morphotypes that we found in our database from a sagittal point of view. Of course, you also have like the classic coronal scoliosis. And last year, Eric did a study like where he looked at the postoperative, what was a predictor of postoperative alignment. And what we found is that the preoperative alignment in extension is what actually guides like the severity of the correction. So basically, if in extension you're still deformed, you're going to do a more severe correction that if the patient like correct based on flexion extension, and the preoperative extension film is actually very similar to whatever you're going to have postoperatively. So I try like to shrink down a little bit this presentation because everybody is going to go like much deeper in their talk later. I will just add one slide. This one is like as of today, unfortunately, we still don't have any disease-specific outcome. And what we're using right now is like, there was ODI. Someone changed a few questions to call that the NDI. There was a SRS-22 that was developed for adolescent. We use that for adult, and we're thinking about changing a few questions to use that for cervical, but that's probably not the right method. So collectively, and everybody should, if you're interested, could jump on this topic. Like, there is a need to understand what is a burden for those patients. How does the disease affect the quality of life? And maybe there is probably a need to develop a cervical deformity questionnaire based on established methodology. Thank you.
Questions for Dr. LaFage?
I think we can, because the next topic are around the same topic.
So
yeah, we can continue, and then like each of us can jump on them.